Imagine a 10-year-old child sitting in front of you in an examination room, and they are in agonizing, like 8 out of 10 pain. They're dizzy every time they stand up.
Right.
They're completely unable to attend school because the fatigue is just so crushing they can barely keep their eyes open. But you look at their blood work, you look at their x-rays, you look at their MRIs, and every single test says they are 100% perfectly healthy.
Yeah, it's a terrifying reality.
It is. And today's deep dive is exploring exactly that terrifying reality of invisible illnesses and really why our modern medical system is fundamentally unequipped to handle them.
It's the absolute definition of diagnostic muddy waters, I mean. And for the families caught in those waters, the experience isn't just frustrating. It is a profound years-long trauma. Because when a child is suffering that intensely and the data shows nothing, the system doesn't just fail them, it often turns against them.
Yeah, exactly. So we are focusing today on complex connective tissue disorders, specifically hypermobile Ehlers-Danlos Syndrome, which you'll hear us refer to as hEDS, and Hypermobility Spectrum Disorder, or HSD. We're going to explore why it is so maddeningly difficult to get children diagnosed when, standard clinical evaluations just fail to show objective evidence.
And our source material for this is entirely drawn from a really comprehensive medical text called Disjointed, Navigating the Diagnosis and Management of Hypermobile Ehlers-Danlos Syndrome and Hypermobility Spectrum Disorders.
Which is such a massive resource.
Well, it's an incredible compilation. It was edited by Diana Joven, and it brings together the clinical insights of over 20 specialist physicians. And these are doctors who work specifically with this patient population. So these are the people in the front lines trying to figure out why these kids are just falling through the cracks.
And the cracks are massive. So our mission today is to uncover those blind spots. We want to understand how the highly siloed nature of healthcare fails multisystemic conditions and really reveal how connecting the dots can quite literally save a child's quality of life. So, okay, let's unpack this. How can a child be so fundamentally sick while looking so incredibly healthy on paper?
Yeah.
Because reading through the source material, it reminds me of a group of mechanics looking at a broken down car, right?
Yes.
You have one mechanic who checks the tires and says they're fine, another checks the oil, another checks the battery. They all confidently sign off on their specific parts. But no one steps back to realize that the car's entire chassis is structurally warped.
That analogy perfectly captures the systemic failure we're looking at here.
Right.
I mean, the chassis in the human body is our connective tissue. It's everywhere. It holds the skeleton together. It forms the structure of our blood vessels, our organs, our skin, our digestive tract.
This is not just joints.
Right, exactly. When we talk about hypermobile Ehlers-Danlos syndrome, we were talking about a heritable disorder where that structural foundation is faulty across the board.
Yeah.
But here is the catch that really initiates this entire diagnostic nightmare. Unlike other forms of Ehlers-Danlos syndrome, like vascular EDS, which is a very specific genetic test.
Right, you can just test for that.
Exactly. But hEDS is the only subtype without a known genetic marker. We do not have a blood test for it.
Which means a diagnosis relies 100% on a clinical evaluation.
Right.
The doctor has to look at the patient, physically manipulate their body, and interpret their subjective symptoms.
And that relies heavily on a diagnostic tool called the Beighton scale. It's a 9-point system designed to measure generalized joint hypermobility. So a doctor will ask you to bend your pinky finger backward, pull your thumb down to your forearm, lock your elbows and knees backward, and basically put your palms flat on the floor without bending your knees.
Yeah, I was actually trying some of these while reading the text, and just attempting to pull my thumb to my forearm felt like I was going to snap a ligament.
Don't do that.
Right, I stopped. But for these kids, the joints just glide right past normal limits.
They do. But the Beighton scale is highly controversial among specialists because it is incredibly limited. I mean, think about it. What if a child's shoulders dislocate constantly and their hips pop out of socket and their jaw frequently unhinges, but their elbows and knees are relatively stiff?
Oh, right. So they'd fail a test.
Exactly. They will score very low on the Beighton scale, completely failing to meet the threshold for a diagnosis, even though their connective tissue is undeniably failing system-wide.
And the text notes that the international diagnostic criteria for hEDS were tightened significantly back in 2017. Like, they made the threshold even stricter.
They did, yeah. And primarily that was to try and isolate a genetically uniform group of patients for research purposes.
Which makes sense for research, I guess.
It does. But the unintended consequence in the clinic was just devastating. Because if a child is hypermobile and suffering, but falls just 1 point short of these new, strict criteria, they are denied the hEDS diagnosis, and instead they're handed a label of Hypermobility Spectrum Disorder, or HSD.
But the source material makes it incredibly clear that HSD causes the exact same debilitating symptoms, like the systemic pain, the crushing fatigue, the joint instability. It is functionally indistinguishable in its severity. Yet HSD often isn't taken as seriously by the broader medical community or school boards or even insurance companies.
It's treated as a lesser issue, which is scientifically inaccurate. And this leads to this pervasive, deeply frustrating phenomenon that patients encounter constantly, which is the whole "but you look so healthy" thing.
Oh man, yeah.
Because the connective tissue failure is internal and systemic, the symptoms are largely invisible during a standard 15-minute pediatric wellness check. We're talking about severe gastrointestinal dysmotility, brain fog, and joints that are constantly subluxing.
Subluxing, meaning they are partially dislocating and sliding around in the socket.
Right. Exactly.
I want to talk about how this invisibility compounds when we look at how kids process pain. Because the text points out that children cope with chronic pain entirely differently than adults do, which actively works against them in a clinical setting.
Right, because a doctor expects severe pain to look a certain way. If an adult is at an 8 out of 10 on the pain scale, they're usually immobile, wincing, guarding the injury, maybe even crying.
Sure.
But a child who has lived with this baseline of pain for years adapts. So a child in a severe pain flare might sit on the exam table and intensely play a video game on their phone or joke around simply as a neurological distraction technique.
So the doctor walks in, sees the kid playing Minecraft, and just immediately assumes the parent is exaggerating the symptoms or the child is fabricating them.
The visual evidence contradicts the doctor's training. Modern medicine is heavily built on objective, measurable markers. We want to see localized swelling, we want to measure a fever, we want a positive blood culture. So subjective symptoms, especially in a child who isn't performing the role of a sick patient correctly, make the medical system deeply uncomfortable. The doctor's default is often to doubt the patient rather than doubt their own limited diagnostic toolkit.
Okay, but wait. I'm struggling to understand something fundamental here. If a child's shoulder literally dislocates or their kneecap slides out of place, there is mechanical damage, right?
Yes.
A bone has left its socket. Tissues are stretched. How on earth does a modern MRI miss that? Are we doing the tests wrong? Because it seems impossible that physical trauma of that magnitude just hides from medical imaging.
It is entirely counterintuitive until you understand the specific nature of lax connective tissue. So in a normal body, if you dislocate a shoulder, the ligaments tear. It stays dislocated, it swells massively, and you go to the ER to have it reduced or popped back in.
Right, they have to force it back.
Exactly. But in hEDS, the tissue is inherently loose and stretchy. So a joint might completely sublux, cause agonizing nerve pain and microtrauma, and then simply slide right back into place on its own a few seconds later.
Wow, so the elasticity actually masks the injury.
Yes. By the time that child gets an MRI approved, scheduled, and executed, they are lying perfectly still inside the machine. The joint is currently sitting correctly in its socket. The image is static. A radiologist looks at the film, sees the humerus sitting in the glenoid cavity, and writes a report saying everything is perfectly normal.
It's like trying to prove a door hinge is loose by taking a photograph of the door when it's perfectly shut. I mean, the photograph will look like a totally functional door. You only see the mechanical failure when you actually open it, and the whole thing wobbles off the frame.
That is a phenomenal way to visualize it, yes. A dynamic injury is being captured by a static, non-weight-bearing test. The imaging completely misses the mechanical failure that only happens when the child is moving or bearing weight or simply fighting gravity in the real world.
So you have a child whose joints are visibly failing in real time, but hiding on the MRI. Their pain is severe, but their coping mechanisms make them look fine. What does the medical system do with them? This brings us to the section of the book that was genuinely infuriating to read. Because connective tissue is everywhere, it affects every system, and our medical system is built on highly specialized silos.
Oh, the silo effect is devastating here.
Yeah.
If we look at the business model of modern medicine, it relies on specialty-specific treatment and rapid patient throughput.
Yeah.
You have an orthopedist for bones, a gastroenterologist for the gut, a cardiologist for the heart, a neurologist for the brain.
Everyone stays in their lane.
Right. The system is fundamentally not designed for multisystemic chassis failure.
I want to trace the illustrative case study of the 8 to 11-year-old girl detailed in the text because it perfectly highlights how destructive these silos are. So between the ages of 8 and 9, she has intermittent joint pain and what seems to be a gluten sensitivity. Mild, kind of odd symptoms, but nothing that sets off alarm bells.
It's the slow accumulation of systemic noise, basically.
Yeah. Then, from ages 9 to 11, the lower back pain kicks in. So she goes to an orthopedist. The orthopedist takes an x-ray, sees a straight spine, and dismisses it as growing pains.
A classic misdiagnosis. Because the doctor is only looking at the bones. They completely miss the fact that the ligaments supporting the spine are failing to hold the skeleton upright against gravity.
Then she starts getting frequent respiratory infections. The pediatrician responds by prescribing multiple rounds of antibiotics. Then they send her to physical therapy for the back pain, and the traditional physical therapy actually makes her pain significantly worse.
Which is an enormous red flag for a hypermobility disorder. Traditional physical therapy heavily utilizes stretching. If you take a joint that is already dangerously loose and apply standard stretching protocols, you are actively destabilizing it further. You are tearing tissue.
So by age 11, this poor girl's symptoms become acute. She has extreme fatigue, massive brain fog, wide swings in her heart rate. She feels awful all the time and is entirely unable to attend school. And what does the pediatrician focus on after all the silent specialists send back normal reports? School refusal?
Yeah.
They miss the physical root cause entirely and suggest the child is having a behavioral issue to get out of class. I mean, can you imagine the psychological impact of being that sick and having the adults in charge of your care tell you that you're just trying to skip math class?
It is the anatomy as a misdiagnosis, and it shatters a child's trust in their own body and in authority figures. We call this the danger of the incomplete differential. A differential diagnosis is the list of possible conditions a doctor considers. When doctors only look through the narrow lens of their specific field, their differential is inherently incomplete.
They are only treating the downstream symptoms.
Exactly. If we connect this to the bigger picture, the gastroenterologist treats the gut dysmotility as an isolated bowel issue. The orthopedist treats the back pain as a localized bone issue. The pediatrician treats the fatigue as a behavioral issue. None of them are talking to each other, so none of them realize they're looking at a unified connective tissue failure.
And the text points out that this is further complicated by the phenomenon of referred pain, which throws the specialists even further off the scent.
Oh, referred pain is incredibly common due to the kinetic chain of the body. So a child might complain bitterly of hip pain. The orthopedist x-rays the hip, sees a normal joint, and sends the kid home.
Because the hip is technically fine.
Right, but the root cause is actually a hypermobile, pronated foot. The ankle is collapsing inward because the ligaments are weak. That bad alignment at the bottom of the kinetic chain forces the knee to twist, which forces the hip to overcompensate, referring pain all the way up the leg. If the specialist only looks at the hip, they will never ever find what is actually wrong.
If you're listening to this and thinking, come on, surely a doctor wouldn't just ignore a patient in pain, you really have to look at the reality of navigating these silos. The parent essentially has to become a medical case manager with a PhD in connective tissue disorders just to get their kid help. The burden of connecting these cross-specialty dots falls entirely on the family.
And they are trying to do this while their child is in acute physical distress. They're fighting for referrals, they're battling insurance companies for out-of-network coverage because so few doctors understand hEDS, and they're dealing with the sheer exhaustion of navigating a labyrinthine system.
So what happens when all those siloed specialists run their tests? The MRI is static, the Beighton score is a point too low, the blood work is clean, and everything comes back, quote-unquote, normal.
Well, this is where the diagnostic odyssey takes a very dark turn. When medical professionals exhaust their specialized tests and find nothing objective, they rarely say, I don't know, this is beyond my expertise. They inevitably default to a much more dangerous assumption, which is that it must be psychological.
The psychiatric red herring. The text highlights a staggering frequency of psychiatric misdiagnoses in this patient population. We're talking about children being labeled with anxiety, depression, conversion disorder, somatoform disorder, and even factitious disorder.
What's truly fascinating here, and frankly terrifying, is how perfectly the physiological realities of hEDS mimic psychiatric disorders. Take dysautonomia, for instance. This is a dysfunction of the autonomic nervous system, which controls everything your body does automatically, like heart rate, blood pressure, digestion.
And many kids with hEDS have a specific type of dysautonomia called POTS, postural orthostatic tachycardia syndrome.
Right, because their blood vessels are made of faulty, stretchy connective tissue. Those vessels lack the structural integrity to constrict properly. When the child stands up, Gravity pulls their blood down into their legs and abdomen, and it pulls there. So the brain suddenly realizes it isn't getting enough oxygen.
So the body panics.
It initiates an extreme compensatory response. The heart rate skyrockets, often jumping 30 to 50 beats per minute just from standing up, trying desperately to pump blood back up to the brain. And the adrenal glands dump a massive amount of epinephrine adrenaline into the system to force the blood vessels to constrict.
Okay, here's where it gets really interesting. So a teenager with POTS wakes up, the alarm goes off, they swing their legs out of bed and stand up. Gravity takes over, the blood pools, and their body literally triggers an immediate adrenaline dump. It's a massive fight-or-flight response, feeling exactly like you're being chased by a bear, just to keep them from passing out on the bedroom floor.
Yes. Now imagine a psychiatrist or a pediatrician listening to that teenager describe their morning routine. A racing heart, a sense of impending doom, sweating, shaking, shortness of breath, and severe dizziness. To a mental health professional relying on the standard diagnostic manual, this looks exactly 100% like generalized anxiety disorder or a severe panic attack.
But if a child is experiencing a literal adrenaline dump every morning due to POTS, treating them with cognitive behavioral therapy for anxiety is basically like giving a Band-Aid to someone with a broken leg, right? Like you can sit in a therapist's office and change how you feel about the puddle on the floor, but the plumbing is still fundamentally broken.
Right.
You can do deep breathing exercises all day long, but it is not going to stop your blood vessels from expanding when you stand up.
It is entirely futile and often actively harmful. As one expert in the book notes, they saw a patient who had undergone 4 years of intensive psychiatric therapy for anxiety.
4 years.
4 years. It made zero improvement in her physical symptoms and actually made her mental health significantly worse. Because for 4 years, she was being told by authorities that her physical suffering was a failure of her own mind. She just wasn't trying hard enough to calm down.
We have to talk about the gender bias at play here, too, because this psychiatric dismissal does not happen equally.
No, it does not. The ratio of diagnosed hEDS in females to males is roughly 3 to 1. The patient population is heavily skewed toward girls and women, and symptoms often violently exacerbate during female puberty.
Because estrogen is a vasodilator. It inherently relaxes blood vessels and ligaments.
So just as these young girls are hitting puberty, their already loose joints get looser, and their already stretchy blood vessels get stretchier. Their joint dislocations and their POTS symptoms skyrocket simultaneously. And because of deeply ingrained historical gender biases in medicine regarding how female pain is interpreted, they are disproportionately told they are just hysterical, anxious, or overly sensitive to normal bodily sensations. There's a horrific anecdote in the book of a provider who literally wrote "weak woman" as the primary diagnosis in a patient's medical chart.
Weak woman. I mean, it's breathtakingly arrogant. But as infuriating as that is, the text outlines a scenario that is vastly worse. The absolute worst-case scenario for these families is the accusation of Munchausen by proxy, which is now often called medical child abuse.
This is truly a nightmare. And to understand why it happens, you have to look at it from the perspective of an emergency room physician. ER doctors are highly trained to look for patterns of child abuse. That is a critical part of their job. Now think about the physical symptoms of unmanaged hEDS in a young child.
Unexplained fractures from very minor impacts because the bone density can be affected. Incredibly easy bruising because the skin and the capillaries are fragile, and frequent joint dislocations.
Exactly. If a parent brings a 6-year-old child into the ER frequently with those specific injuries, a dislocated shoulder 1 month, bizarre bruising up and down their legs the next year, the ER staff will flag it. They don't look at that and think, an incredibly rare presentation of a connective tissue disorder. They see a child who is constantly bruised and broken, presenting with textbook markers of physical abuse.
And the parent, who's been gaslit by doctors for years, comes into the ER highly anxious, demanding specific tests and acting overly involved because they know they have to be the case manager.
To the ER staff, that parent looks like the perpetrator of medical child abuse. They suspect the parent is either physically harming the child or fabricating the illness to gain attention. Child Protective Services is called in. The child might be temporarily removed from the home. The family is subjected to state investigations.
The tragic irony is that the parent is desperately seeking help for their sick child, and the medical system responds by turning them into a suspect. It completely destroys the family's trust in medicine. How do you ever walk back into a hospital after that?
It is incredibly difficult to repair that relationship, and the root of this conflict often traces back to the medical community's inability to recognize the physiological reality behind these bizarre symptoms. Take another example from the book, the cervical spine.
Right, craniocervical instability. This blew my mind.
The ligaments holding the skull to the spine are often lax in severe hEDS, so the head literally bobbles on the neck. This can lead to the spine compressing the brainstem and the cranial nerves. The brainstem controls vital autonomic functions. When it is compressed or stretched, it triggers severe, bizarre neurological symptoms. A child might have staring spells, temporary memory loss, extreme brain fog, or sudden loss of motor control.
And a neurologist looks at a child having pseudo-seizures or sudden weakness, runs a standard MRI, which again is static, sees nothing obvious, and labels it conversion disorder. They assume the child's psychological stress is converting into physical symptoms.
When a doctor dismisses brainstem compression as conversion disorder, it creates a toxic, deeply defensive dynamic. The parent sees their child physically failing and knows something is profoundly wrong. The doctor thinks the parent is enabling a psychiatric delusion.
So you have a child who has essentially been medically gaslit by 5 different specialists, handed off to a psychiatrist, or flagged by social workers. What does this delay, this years-long diagnostic odyssey, actually do to a developing brain and nervous system over 5 or 10 years?
The physical and emotional toll is staggering. The research detailed in the book shows that diagnostic delays in children directly and unequivocally lead to chronic, severe, intractable pain later in life. When hEDS is left unmanaged, the constant onslaught of joint subluxations, micro tears, and autonomic stress causes a neurological phenomenon called central sensitization.
Central sensitization. Let's break down exactly how this happens. The nervous system basically gets stuck in overdrive.
Yes. Think of the nervous system as the body's alarm system. Every time a joint subluxes, an alarm goes off. When hEDS is unmanaged, that alarm is ringing constantly. Over time, due to neuroplasticity, the brain and the spinal cord become hyperreactive. They fundamentally rewire themselves to expect pain.
It's like someone turned the volume knob on the alarm system so high that even a gentle breeze sounds like a fire siren.
That is exactly the mechanism. A minor stimulus, like a light touch or normal daily movement that shouldn't hurt much, is suddenly perceived by the brain as agonizing. The nervous system is amplifying the signals. And once central sensitization sets in, it is incredibly difficult to reverse.
And that amplification leads directly to kinesiophobia, which the text defines as the fear of movement.
And we have to emphasize that for these children, it is a completely rational fear. Because, as we discussed with the physical therapy example earlier, movement has historically hurt them. If a physical therapist applied standard joint mobilization techniques to them, it caused massive symptom flare-ups.
Right. The child's brain makes a very logical connection. Like, every time I exercise or go to PT or run in gym class, my shoulder pops out and I am in agony for 3 days.
So they stop moving.
They stop moving to protect themselves. But when they stop moving, their muscles atrophy. And because their ligaments are already useless due to the faulty connective tissue, they desperately need muscle tone to hold their skeleton together. When the muscles atrophy, the joints lose their only remaining support, which makes everything worse.
So much worse. They become even less stable. The subluxations increase, the pain increases, and the fear of movement deepens. It becomes a vicious downward spiral of deconditioning.
But the flip side of this nightmare is the immense power of an accurate diagnosis. There's a quote from a parent in the book that just stopped me in my tracks. They had finally secured the EDS and POTS diagnoses for their 17-year-old daughter, who by that point was utilizing a wheelchair due to the deconditioning. The mother said, physically, she's the worst she's ever been, but emotionally, she is the happiest, least anxious, and most stable that I have ever seen her.
What's fascinating here is how it perfectly illustrates the life-altering power of validation. Knowing it isn't all in her head was transformative. After a lifetime of feeling like her own mind was responsible for her health problems and believing that if she just tried harder in therapy, she'd magically feel better, she finally had proof. She was fighting a real, physical, genetic battle.
So if a child is actually lucky enough to get diagnosed at 8 years old instead of 18, what does early intervention actually look like? Because we've established they can't cure the faulty connective tissue. You can't fix the chassis.
No, you can't cure it. But early diagnosis is entirely about preventative maintenance. It changes the entire paradigm of how the child is managed day to day. Educationally, you put a 504 plan in place immediately. You get duplicate textbooks so the child doesn't have to carry a heavy backpack that destroys their fragile spinal alignment. You allow them to carry a water bottle and salty snacks to manage their POTS.
And you completely change the approach to physical therapy.
Dramatically.
Yeah.
You fire any PT who pushes standard stretching. You focus entirely on proprioception. Proprioception is the brain's ability to know where the body is in space. Hypermobile kids often lose this map because their joints stretch too far. So you teach the brain to find neutral joint positions, and you build microstability in the tiny stabilizing muscles surrounding the joints.
And for the dysautonomia, like the POTS,
You stop throwing antidepressants and anti-anxiety meds at an autonomic nervous system failure. You address the physical blood pooling, you prescribe high sodium intake, aggressive fluid hydration, and medical-grade compression garments for the legs and abdomen to keep the blood volume up and force it back to the brain.
what's fascinating here is how these interventions are essentially giving the child and the parent a highly specific instruction manual for a very unique type of body.
If we connect this to the bigger picture, an early diagnosis removes the profound guilt and guesswork from parenting a chronically ill child. It allows families to understand the difference between good pain and bad pain. They know when a child needs a gentle, parental push to stay active and maintain muscle tone, and when they legitimately need to rest for 3 days to avoid a catastrophic symptom flare.
It intercepts that downward spiral before central sensitization and kinesiophobia can take root.
It changes their entire neurological trajectory.
Okay, let's recap the journey of this deep dive because it is heavy and it is complex. We started with the paradox of invisible symptoms, a child whose connective tissue is failing in every organ system, but who looks completely fine sitting on a pediatrician's exam table.
We navigated the maze of our siloed medical system, where every specialist only evaluates their specific, isolated body part, entirely missing the systemic failure of the chassis.
We explored the terrifying pitfalls of psychiatric misdiagnoses, where physical autonomic dysfunction like POTS is written off as anxiety, and how gender bias accelerates that dismissal, leading to unimaginable scenarios like medical child abuse investigations.
And finally, we looked at the absolute necessity of early, accurate intervention to prevent a lifetime of amplified pain and the psychological freedom that comes with simple validation.
For anyone listening, whether you are currently navigating the medical system for yourself, fighting for a child, or supporting a loved one, the overarching takeaway from the dozens of specialists in this book is clear. Because our medical system is functionally siloed, it is not going to connect the dots for you.
You have to step into that role. You have to be the case manager, synthesizing the information across specialties. Understanding that reality and learning to advocate effectively in those clinical spaces is a vital life skill.
And we started this deep dive talking about x-rays, broken bones, and the comfort of the objective, visible diagnosis. Right now, hEDS is diagnosed purely by clinical evaluation, relying on flawed tools like the Barton scale, because we haven't found the specific genetic marker for it yet. But genomic science is moving incredibly fast. What happens 5, 10, or 15 years from now when we do discover that gene, when we can finally put this invisible illness on a metaphorical x-ray, point to a sequence of DNA, and say, there it is? Will the medical establishment have to look back and issue a massive retroactive apology to an entire generation of children and parents who were told their very real genetic pain was all in their head or just school refusal?